Hey everyone, and welcome. So, as a trainee, you've probably seen those patients with really frustrating gut symptoms, where the usual workup just isn't giving you answers. Well, today we're diving into gastrointestinal motility testing. Think of these as the specialized tools in your diagnostic toolkit that help you figure out exactly what's going on. Let's break down how they work, and maybe even more importantly, when you should be using them.
Okay, let's start with a classic scenario. You have a patient, they've got chronic constipation, and nothing you've tried is working. The big question is, why? Is their entire colon just sluggish, what we call slow transit? Or is there a problem right at the very end, an outlet issue? This is exactly the kind of clinical puzzle where motility testing lets us stop guessing and start getting some real, concrete answers.
So what's the whole point of these tests anyway? It's really about getting to the root cause of the problem. Instead of just throwing laxatives or antidiarrheals at symptoms, these tests let us see the actual mechanical or neurologic breakdown that's causing all the trouble. It's the difference between just managing a problem and actually diagnosing it.
And the reasons to order these tests are pretty broad. They cover some of the toughest complaints we see in GI. Of course, there's chronic constipation and diarrhea, but we also use them for things like dyspepsia, that nagging, unexplained upper abdominal pain. They're even crucial for seeing how a systemic disease, like scleroderma, is affecting the gut. It really shows you just how versatile these tests can be.
All right, first up is a real workhorse, the radio-opaque marker study. This is often your first step when you want to check out colonic transit time. Why? Because it's simple, it's widely available, and it gives you a clear answer to a very basic question. How fast is stuff moving through the large intestine?
The protocol itself couldn't be more straightforward. On day 1, the patient just swallows a capsule that has 24 tiny markers inside. Then, and this is key, they have to stop all their laxatives for the next 5 days. Finally, on day 6, they come in for a single, simple abdominal x-ray. We're just looking to see how many of those little markers are left. It's a pretty low-effort test for the patient, which is great.
So, how do you read the results? Well, it all comes down to a simple number: 20%. If that X-ray on day 6 shows that more than 20% of the markers are still hanging out in the colon, so that's 6 or more of the original 24, then the test is positive. You've got delayed colonic transit. It's a nice, clean, quantitative answer.
But wait, there's more to it than that. The test is actually more powerful than just a simple yes or no on slow transit. Where the markers are located gives us a huge clue. If they're scattered all over the colon, that suggests a global slow transit problem. But if they're all bunched up down in the rectosigmoid area, that points toward an outlet delay. Now here's a really important catch. You can't officially diagnose slow transit constipation until you've ruled out an underlying pelvic floor issue called dyssynergia.
The marker study is fantastic for the colon, but what if you think the problem might be starting earlier, in the stomach or the small bowel? For that, we need a tool that can see the bigger picture, and that's where the wireless motility capsule comes in. This little piece of tech gives us an amazing, dynamic view of the entire GI tract. Just think of this thing as a smart pill. It's basically a tiny probe that gathers data as it makes the long journey through the gut. It's constantly measuring pH, pressure, and temperature. For example, that sharp drop in pH tells us exactly when it left the stomach, and a rise in pH tells us when it hit the small bowel. This lets us calculate gastric emptying time, small bowel transit, and colonic transit, all from one test and with no radiation.
So let's put these two tests head to head. The big difference really boils down to scope and radiation. Radio-opaque markers, they only look at the colon, and they use a tiny bit of radiation. The wireless capsule, it sees the whole gut, and there's zero radiation involved. Now, it is more expensive, but for those really complex cases, like when you suspect gastroparesis on top of slow transit, the wireless capsule is absolutely invaluable.
Okay, so far we've talked about the journey through the gut. But what happens if the problem is at the destination? To really understand the incredibly complex mechanics of defecation, we need a totally different tool. And that tool is anorectal manometry. This is the gold standard for checking out the function of the rectum and the anal sphincters. So when do you order this? Well, there are a few key situations. If a patient has fecal incontinence, manometry directly measures their sphincter strength. If they have constipation and feel like they just can't empty completely, this is the definitive test for an outlet obstruction or dyssynergia. And what's really cool is that it's not just for diagnosis. It's also therapeutic because it gives us the data we need to guide biofeedback therapy.
Now, most modern labs use what's called high-resolution manometry, or HRM. The huge advantage, like the slide says, is that once the catheter is in place, you don't have to move it. The old-school methods required this pull-through technique, which could be uncomfortable and mess up the data. HRM gives us this beautiful, continuous pressure map of the whole area, which means much more reliable data.
All right, I'll admit it, when you first see a manometry report, it can look a little intimidating. It's just a bunch of pressures and squiggly lines. But let's break down what we're really looking for. We're not just looking at numbers, we're translating those pressures into understandable patterns of function and dysfunction.
A complete study really looks at 4 main things. First, anal sphincter function. We check the pressures at rest and during a squeeze to see how strong those muscles are. Second, we test rectoanal reflexes to make sure the nerve pathways are working. Third, rectal sensation. Can the patient actually feel when there's stool in the rectum? And finally, the most important part for dyssynergia. We look at what happens to the pressures when the patient tries to bear down.
One of the most critical reflexes we check is the rectoanal inhibitory reflex, or RAR. Normally, when the rectum stretches from stool, the internal sphincter should automatically relax a bit. If that reflex is absent, it is a major red flag. It's the classic finding in Hirschsprung's disease, and it can also point to other nerve-related issues.
And that brings us to one of the key diagnoses we make with manometry: dyssynergetic defecation. Put simply, this is a coordination problem. When someone tries to have a bowel movement, their pelvic floor muscles are supposed to relax to open the door. With dyssynergia, they either don't relax, or even worse, they squeeze tighter. It's literally like trying to push against a closed door.
And this dysfunction gets broken down into 4 types based on 2 simple things: how well the patient pushes and what the anal sphincter does. In types I and 3, the patient is pushing hard enough, but the sphincter isn't relaxing properly. In types 2 and 4, the push itself is too weak. This distinction is so important because it tells us exactly what to work on in biofeedback. Do we need to teach them how to relax the sphincter, how to push better, or maybe both?
Okay, so let's wrap this up with the key takeaways. Think of it like this. For a simple question about colonic transit, start with the radiopaque markers. It's an easy first step. If the story is more complicated and you think the upper GI tract might be involved, that's when you should consider the wireless capsule. And finally, if you suspect a problem with the exit and outlet issue, then anorectal manometry is your essential must-do test.
And that's our whirlwind tour of GI motility testing. So the next time you have that really challenging patient with GI symptoms that just won't go away, remember these tools. Picking the right test for the right question can completely change your diagnosis and, more importantly, your patient's life. Thanks so much for tuning in.